Bismillahirrahmanirrahim. All right, so today the topic of discussion is we see a lot of patients with ischemic heart disease, and the most common reason for consultation after an angiography is whether they should go for bypass or do they want stent. And this is something which I thought might give you a good idea as a multi-specialty group of consultants and physicians and healthcare providers, and this might be able to answer a lot of our questions. So the learning objective for today's presentation is that case selection. How do we select a case who's good for bypass, and what are the cases which are good for stenting? How to identify and timely diagnose with angiography. A lot of our patients, they present very late to a cardiologist, and many a times they are being screened by internal medicine or other specialties, but they keep treating them for just medical therapy, leading to advancement in the disease burden over time. So the sooner we do angiography, the sooner we are able to pick up those cases, and maybe we can control their disease and progression much more aggressively, even with medical therapy. Angiography does not actually mean you need to get stent right away or you need bypass right away, as long as you do it early enough. But once you delay a certain point, many a times you don't have any option than bypass. And I'll show you some cases in which even the bypass is too late. And we tell them that this is an end-stage heart failure case in which nobody is willing to take a chance. We're going to do a simple overview of coronary anatomy, and I'll show you a hands-on kind of little bit exercise in which we can put in the information of the coronary anatomy in a system, and it tells us the score. Objective score based on that if we do bypass, what are the outcomes, and if we do stents, what are the outcomes. So that is a way for your educated patients that if you are able to show them this data, that will help them understand the risks for their decision and the merits and demerits of each decision. The criteria for stenting and the best patients for bypass, that's what we're going to discuss in today's presentation. So I don't have any disclosures. There might be abbreviations being used. PCI means percutaneous coronary intervention, which in easy words is a stent. Stent is a mesh of a small tube. So it is done percutaneously. We use radial artery or femoral artery. And the way we are doing angiography is the same way we are able to deliver this undeployed stent to the area of blockage, and we dilate the blockage. Coronary artery bypass is called CABG, C-A-B-G. So this is something which is an abbreviation being used for open heart surgery. So open heart surgery also have certain types. We are not going to go into details because that's a little more technical, but most of the people are actually opting for this as a last resort. They normally say that if we get this done, that's kind of like end of our life. But in reality, if it's done timely, it's actually a better option for certain group of patients that we're going to be discussing. So it has been an internal debate for patients who need bypass or stents. And we actually want to reach that point before the cardiac arrest happens, sudden cardiac death, because of ischemic heart disease, arrhythmias, VT, VF. So this is something that we would like to be settled, mentally comfortable with that decision so that we can actually give them the right advice. So coronary artery disease, first thing is protoplasm, the patient by themselves. When they come, they present with angina. It might be unstable angina or it might be a heart attack based on what their ECG is showing, if they're ST depressions or ST elevation. We do objective assessment by TIMI risk score or GRACE score, and that helps us guide our teams how aggressively you want to cater this patient. Because most of these patients, when they come in with a non-ST elevation MI or STEMI, that definitely is an emergency. For STEMI, we need to do an angiography within a matter of 1 to 2 hours. And for non-STEMI, the advisable is to do it within 24 hours. So many a times for high-risk cases, you have to do it even within 5-6 hours. So that depends on how urgently this patient is coming. Unfortunately, the exam part is usually normal as long as it's just ischemic heart disease. But when it's complicated with heart failure, you would have crackles, high JVD, S3, edema on the legs. So those findings can be found on these. ECG, many a times is misleading because many patients, ECG is a dynamic test. Means that when they are having chest pain, during that time only, the ECG would have changes. but 1 or 2 hours before or after, ECG might be normal. So anyone coming with chest pain 2 hours ago with a normal ECG does not mean they don't have ischemic heart disease. So the protocol by both European Society and American College of Cardiology are that you need to admit these patients for observation, repeat serial ECGs, do at least 2 sets of troponin, and if they are negative, then you send them as an outpatient workup for their risk stratification, whether they need a stress test or so. Echo can give us some idea if they have some structural changes. Some area of the heart being weak, any mitral regurgitation can tell you ischemia. So echo is a good test from that point of view, but it can be normal in many of these cases with angina or unstable angina. Troponin we spoke because once this is positive, that becomes a class 1 indication. It's a MI, whether it's non-STEMI or STEMI based on what ECG is showing. You do chest x-ray and you do screening in terms of lab to see if they have renal dysfunction, liver dysfunction, any other abnormalities going on. Chest x-ray, CT lung, COPD changes, head CT for prior strokes, CT angio if anything is done. Ask about other manifestations of peripheral vascular disease, ulcers on the feet. And the idea is to gauge these people whether you want to do a CT angiography or you want to do a conventional regular angiography. So whenever the troponin is positive, it is always a good idea that you go for conventional, because these are the patients who eventually are going to need some intervention. So doing a CT angio will give them contrast, will give them radiation, and the report is going to be 24 to 48 hours later. So, and that's a diagnostic test that delays the treatment. So especially if somebody is having really high pre-test probability, unstable angina, non-STEMI or STEMI, these are the ones who actually are better taken care of with conventional angiography. And you can actually diagnose which is the plaque, which area in the artery that is needing your attention and treatment. So this is a basic coronary anatomy. And I'm just, for ease, what I've done is each number, I have given the number right in front of it. Like this is left main. So this is where the 70 to 80% of the heart is getting supply. So if somebody has disease right in the beginning, it's called ostial disease, the proximal disease, these patients, mind you, are better off for bypass. Okay? Especially if they're involving the bifurcation. Because stent is a simple straight tube. And if you do, and I'm going to show you some cases in which there are attempts in which you do bifurcation stenting, trifurcating stenting, that just increases the metal in the coronary and more chance of developing a clot in the middle of the night leading to sudden death. So doing stenting in these areas, major bifurcations are normally not without hazard. Then your left main divides into a circumflex and the main LED which goes to the apex of the heart. The branches which come on this side are diagonals. We call it D1, first diagonal, D2. And this way the artery coming are the septal arteries. So LAD has proximal, mid, and distal. Septals and diagonals. Circumflex actually goes in the AV groove, and it gives supply called obtuse marginal artery on the surface. So the surface vessels are the one in which you can put the bypass. The groove artery, you cannot put the bypass in there. Then is the right coronary artery, in which there is one vessel going to the SA node, AV node, RV branch, and then there is a PDA, which goes to the bottom of the heart, and RPLA. So these are the right coronary artery. The names are there. And the reason I'm telling you this nomenclature is that when you do angiography, we'll look at these vessels. And then there's a scoring system called syntax score. And you can put these lesions, and lesion mean if the blockage is more than 70% or so. So if there's an artery like a circle in a cross section, and the plaque is covering 70% of the lumen, that means it's a 70% blockage. So those are the lesions that we put into our syntax calculator, and that gives us an idea that whether this patient would be benefited by angiography, angioplasty with stent versus bypass. So when you do a surface ECG, so our focus is towards the territories which represent certain areas. For example, for a right coronary artery, or in some cases, 15% of cases, the circumflex supplies the bottom of the heart. And that is represented by lead 2, 3, and AVF. on the ECG. 2 and 3 are the limb leads. All these limb leads through 3 AVF, if they have ST depression or elevation, that means the inferior part of the myocardium is being jeopardized. When you talk about the anterior wall MI, it's V1 to V4 on the surface ECG. These are chest leads, V1, V2, V3, V4. So if the ECG changes, depression or elevation are in this, we know that the problem is in the LAD territory. Then is the circumflex, which is represented by the lateral leads. In the chest, V5, V6, and in the limb leads, 1 and AVL. So these are the regions of myocardium which we want all our medical officers to be comfortable with while interpreting the ECG. So people in CCU, ICU, they are already trained. They think territory-wise. So whenever they tell us the ECG, they don't say lead 1 and 2 and 3, because 1 is different area, 2 and 3 are different area. So they tell us lead 2, 3 AVF has ST depressions, or lead V5, V6 has ST depression. So we know they're talking about lateral wall, which arteries involved. So you have to think territorial-wise when you're doing this. So acute versus chronic. Patients who come in with acute heart attack are never taken for bypass because the surgeon believes that the myocardium is so inflamed at that time that if they do stitching, the stitches won't even stay there. They will slip, leading to tamponade and cardiac arrest and all those problems. So unfortunately, for majority of acute cases, you have to go towards cath lab. They're having a heart attack. They might come a little bit late, but the surgeons are never comfortable taking acute STEMI patients or acute MI patients for bypass. So most of the time, we have to see their stability. It means hemodynamic, whether they need pressures, whether they are having arrhythmias, VT, VFib, AFib. So we have to stabilize all that. Most of the time, we don't have time to do blood tests to see what their renal is, so we have to rely on the history. Unfortunately, most of the patients don't know whether they have kidney disease unless they have been getting treatment for high creatinine. Pulmonary-wise, we normally ask for smoking. And if somebody is going for CABG, this is the workup they normally like to do for that patient in 24 hours before their patient's going for bypass surgery. And of course, we try to decrease their bleeding chances by reducing their dual antiplatelet. It's always a good idea to do a heart team approach, involve the surgeon early, let them see the angiography report and the patient so they can assess the patient. Most of the time, I tell my patients that what we are seeing on the angiography did not happen today. It happened over many months and years. So even if you are looking at a triple vessel disease, means LAD, circumflex, and RCA, all 3 diseased, that disease or blockage did not happen on the day of angiography. It happened over a period of time. So there's no need to rush or tell them that you need to get it done right away. Unless they are hemodynamically compromised, they're having arrhythmias, they're having pulmonary edema, they need to be intubated. So those are the patients in which you have to do something in the cath lab. So especially if the anatomy is complex, I know the patient's family is going through a lot of stress. I try not to rush for PCI. I normally stabilize the patient, let them cool off, let the information sink in, see the surgeon, and if the surgeon and patients and family decides later that they don't want bypass, then I would take them for multi-vessel PCI or stenting. So these are the arrhythmias like VT, VF, atrial fibrillation going on. So whenever this is, you have to stabilize, and sometimes with the right coronary artery, you see complete heart block. And that's an electrical heart block. So you need to put a temporary pacemaker to buy some time. At the same, we have to see many a times on the table with acute ischemia, patients are going to VT, VF, you have to cardiovert them, you have to do CPR, and you have to intubate them. So all these factors go into deciding what you can do. And like I said, unfortunately, most of these patients are not good candidates for going to the theater for bypass right away. Their mortality is high, their outcomes are worse, so we have to come up with something, putting a balloon pump. Sometimes the clot is occluding the artery so much that you don't know what is beyond that clot. So we put a wire, balloon it, and once we see that all the vessels are severely diseased, we can't put so much metal or stent. So just doing a POBA, plain old balloon angioplasty, is many a times give us enough time to stabilize all these arrhythmias, the cardiogenic shock, and then the patient can go for a bypass in 3 to 4 days once they are stabilized with pressor support. So these are the things which are protoplasm, patient-based, their anatomy, their comorbidities, and that defines what to do. Technically speaking, if you see a coronary, it's like a 2-millimeter vessel. So you're crossing a wire through it, a balloon, and a stent is like a metal mesh, like a tube shaped, and it keeps the artery open and it just squishes the plaque on the side. It doesn't actually remove it like most of the people believe that we are able to scrap the atherosclerotic plaque out. That's not the case. These are hard calcified kind of areas unless there's an acute clot that we do have an ability to suck out. But apart from that, most of our cases are there to trap the clot between the stent and the wall. And that's what we do in most of our cases. So whenever me and Dr. Haroon are doing intervention, our best patient is someone with a focal disease. All the vessels are otherwise fine. So there's an area with a very tight stenosis, and it's a focal area less than 15 or 20 millimeter. This is the kind of patient who is excellent for PCI or stent. You might have the similar kind of blockage here, preferably a straight artery. It might be circumflex, it might be RCA. But whenever it involves a bifurcation, that increases the complexity of the procedure. So whenever we are seeing left main, I told you, proximal LAD is the very starting part of the LAD. So these are technically patients who do better with bypass. If they have a lot of calcification or bifurcation requiring 2 or more stents, that becomes a problem. Chronic CTO, chronic total occlusion, old closed arteries are difficult to open because you have to cross the wire, your wire might not cross. You might not be able to cross even the balloon or stent. So that increases the complexity or the success of your procedure. If there are tortuosities, not even in the coronary, but even your access, the femoral is like tortuous. The aorta is tortuous. The subclavian through which you are going is tortuous. We don't have enough support. And then to park a guide and to engage it rightly and to push this metal down, it becomes a big challenge and not an easy thing. And patient does all kind of like funny stuff. They become vagal, heart rate goes to 30, 40s, you're sweating yourself as an operator, the patient is not feeling well, the whole team has a lot of stress, patient is going with a BP of 60/40, and you're kind of like manage, is there something leaking, any bleeding is happening, femoral area, coronary area, or it's just a vagal response. So all these are challenges while we are taking care of our patients in the cath lab. So technically, how many stents can you put? There's a case report in JACC in which 64 stents were placed in a patient, which is totally unwarranted for, but since it was so unusual, it became a JACC article. So how long the artery has been closed? Many a times, the lucky patients, they come in within 1 or 2 hours. The success is very good, the clot is fresh, you put a stent in, patient becomes chest pain-free, comfortable, hemodynamically stabilized, no arrhythmias, and that's a happy moment for everyone. But what if this closure time is more than 12 hours? What if it's already too late? The anterior wall is all infarcted. Then there's not much benefit. But the thing is, when patient is there with cardiogenic shock, for a young guy, you feel like it's been 10, 12 hours. There might be some level of ischemia that can be relieved by putting a stent. So in those cases, you're kind of like dabbling with this thought, what to do, and you end up putting a stent just because you want to give the best chance to that young individual. Procedural details are the ones which actually, and the equipment used. These are also based on what is availability in your cath lab. You might not have all the tools that you need. So you have to kind of like manage these patients based on the size of balloon, the size of stent, the kind of wire to cross, and all these things comes into detail while choosing your strategy for opening up these patients. Calcification, tortuosity, deliverability, we already spoke about these two, that normally these increase the complexity, decrease the success rate for our patients, so we end up trying not to do too much metal in these cases. So we're going to do a little bit exercise about syntax score, which I don't know whether I'll be able to do, so I'm going to leave it to the end so that we can have a flow of our conversation regarding that. CT angio. So on CT angio, normal coronaries are able to be seen. You can see the calcium level, you know, the LAD, the diags, circumflex, left main, the amount of calcium. When you're doing a CT angio for bypass, this I just wanted you to get a visualization, because the surgeons, they normally don't fiddle with the blockage. Just like any bypass, what they do is they take this left internal mammary artery, they close off its branches, and they put it on the LAD. So you can see there is a big aneurysm in the left main, and this lima to LAD is right over here. Though this is another vessel, and then there is another branch which is coming up, and there is an SVG to OM, in which they're doing is they make a small hole, and they put a vein taken out of the leg, and they bypass your blockage and put the bypass next to the blockage so that they can restore the flow beyond the blockage. And I think the schematic one wise, I'm going to show you another example. So this patient, this is the angiographic image, all black and white, nothing rosy about it. The catheter, the coronary, and you can see where the vessel is thick, it's normal, and this is a long area of blockage. Once you put a stent, that's how it looks. You kind of like normalize its lumen, but it might require 1 or 2 stents. This is circumflex and this is LAD, and you can see the caliber of the vessel is much smaller. How do you decide a caliber of a vessel? Is that you actually compare this with your catheter. Your catheter is 2 millimeter, and the vessels that a surgeon would like to put grafts on needs to be more than 2 millimeter. You can see here a bifurcation lesion in the circumflex. This is obtuse marginal, this is obtuse marginal 2, and this is the circumflex, which is in the AB groove, a very small vessel. And after stenting, you can see it looks much nicer with the improved flow. But doing 2 stents in this, putting metal over here, there's always chance that you might form a clot in this area. This LAD was 100% blocked. So this going to all the way down, putting a stent restores this patency. So doing like 4 or 5 stents, the patient is very happy. But in reality, what's going to happen? He has such a profound disease that he should have gotten bypass. Bypass didn't happen. Why? Patient might have bad lungs, COPD, intubation, might have one lung collapsed, might have some other comorbidities which, or patient flatly sometimes refuses, I'm not going to get bypass. So these are the kind of patients with the top line that we don't do intervention right away. We let them see the surgeon, take them off the table, and if due to any medical or social reason they don't opt for bypass, then we bring them back and do multi-vessel PCI. Not the perfect thing, because of a very important reason. And that reason is patients forget how bad it was. The angioplasty process seems to them 2 months later as if just an hour on the table. So they stop taking their medications, they keep smoking, they don't change their lifestyle what they're supposed to. They should see a psychotherapist for that. They don't. And then the same eating habits are back, kadaiyan, everything the same, halwa puri, maghaz, nehari. So these stents don't stand in front of those diets. And this is just going to go down in 6 to 1 year or so. And then again, they're going to be, after spending 6-7 lakh, back to square one, needing Dr. Zubair's open heart surgery. So in cases like this, surgery is excellent. They get a big cut, scar. Every morning they see it, reminds them. They don't want to get it done again, right? So big behavioral change once they get the bypass. So bypass has a long-term, much benefit psychologically as well, apart from other medical reasons which are there for bypass. You see this severe triple vessel disease in which they're doing all these, I would say, kartab, like putting all these different stents, putting all the wires, the bifurcation looking so bad over here, and then they put one wire, one balloon, one stent, open up, one stent, crushing it, then doing all these trifurcation stenting. Problem is that this metal is never going to get endothelialized, and they have to be on dual antiplatelet for the rest of their life. And even on 1 or 2 days, they get diarrhea, motion, don't take Plavix. A clot is going to form, and this patient will never reach hospital alive. They will have a sudden death at home, requiring CPR, and they will come to your ER with a flat line. So whenever you're doing these kind of tricks, They're very technically, I mean, makes your doctor, your operator very happy. But unfortunately, for long term, this guy putting a stents with such a disease might not. But what if it's a cancer patient? Then you can do it, because those patients are not good. Their life expectancy is not more than 1 year. So doing the bypass on a cancer patient, so justification comes from a lot of clinical and social things that we don't know. So that's why I just wanted to put up these examples. Whenever you have severe triple vessel disease, the bypass, so this is how a graft, so the blockage is here, and your graft with the saphenous vein is coming beyond like a bypass. So they don't fiddle with this, they just put the bypass afterwards. Your natural lima, you just have to clip the branches here, and you put it on the LED beyond this left main disease. So the LED will have the restoration of blood. And mind you, this is the best thing, lima is the best thing that a patient with left main disease can have. As long as they have lima, they will never go into heart failure. And the patency is more than 20, 30 years. You need just one lima and you will never need heart failure therapy or so, unless this was done in time. God forbid, if the LV was already scarred, damaged, putting this might not help. So left main disease, especially distal bifurcation or trifurcation, CABG is best. Proximal ostial LED with RCA disease, CABG is best. Long CTOs, especially in the proximal area, whether it's RCA and you have distal vessel which is graftable, the size of the vessel is more than 2 millimeter, always better to have bypass. EF low, many a times this becomes a reason that patients are told you cannot have angiography because your heart is too weak. It's wrong. You can stabilize them, they're able to lay flat, do an angiography, at least delineate their anatomy, and then decide the best for them. A lot of trials have shown that diabetics do much better with bypass rather than stents, because the sticky blood blocks your stents much quicker. But bypass has such a great flow that your diabetic patients are able to keep these bypass open much longer. So this is the best thing if you give them a lima. And that's why many a times there is an approach called hybrid approach, in which what they do is mini sternotomy, take 2 ribs out, do a lima with an endoscopic harvesting right here, and they can stent the RCA, stent the circumflex. But as long as they have the benefit of lima, then these are good for long-term patency of their main 70–80% of the heart. So somebody with severe triple vessel disease having multiple areas, so that becomes a problem, because you can put a graft here, restore the flow beyond it. But this is going to be still little ischemic area. Circumflex, multiple blockages over here. So that becomes a problem, because in that case, where are you going to put your bypass? So the surgeons many a times put a graft here, and they do atherectomy. They can scrape off the atherosclerosis and restore this, but there's always a problem of your LV going down, because patient's EF might be better in the beginning. After atherectomy or long ischemic time, the EF might go down. At the same time, very complex anatomy with a lot of bridging collaterals in the RCA, it becomes a really difficult thing. But then the bypass putting over here, not fiddling with this, is easier, and that is a patient who might do well with bypass surgery. So sometimes it's even too late for bypass. When the vessels are, due to advanced diabetes or smoking, very thin caliber, like a millimeter. So the surgeon is saying, where should I put my bypass? Sometimes you don't even see an artery because it's totally occluded. So diabetics, smokers, someone with severe MR, low EF, pulmonary hypertension. So these are the patients who are very high risk for bypass surgery. LED is so diffuse disease that a surgeon does not see where to put the graft. So those are the patients that unfortunately have no real outcomes. They have cardiogenic shock, scarred LV, thinned out that we can see aneurysmal on the echo, or if their viability is done with a nuclear scan. So these are the patients who won't get much benefit by revascularization. Or if they have advanced renal dysfunction, pulmonary edema, so their comorbidities make them very high risk for any kind of revascularization. So the kind of cases in which the vessel is very thinned out, in which there is no real targets, all distal vessels. Okay, bypass can be placed here, then we are looking at the same outcomes. Then your obtuse marginal artery, LED artery, the caliber is so much, distal vessels are not there. So that becomes severe triple vessel disease in which doing a bypass is not worthwhile. So take-home messages. Early recognition of coronary anatomy is important. So if somebody has classic symptoms, get them evaluated. Doing an angiography will tell you, rather than shooting your arrows in dark, knowing exactly what you need to treat, whether with a stent, medical therapy, or you need bypass surgery. How is your patient? And then technical considerations. Both are decided in order to decide whether you want a bypass or a stent. Patients who have diabetes, hypertension, low EF do better with bypass surgery. Always look at their comorbidities. Do a syntax score, and I'm going to do this now. And lastly, we spoke about the hybrid approach, in which these patients can have a lima with minimal invasive surgery, good post-op recovery within 2 days, and you can put a stent either in the same admission or a couple of weeks later. So that's something that can be done in cases like that. So with that, let me see if I can do the syntax score and just give you a little demo of how objectively we can take care of these patients in terms of assessment. So this is how the anatomy is defined. And there are two things in which you have to define whether it's a dominant system left or dominant system right. The definition is with RPDA. So if the RPDA is coming from the right system, it's a right dominant system. The bottom of the heart, which vessel is actually supplying them. So that's where the difference comes. So we choose, say, like right dominant system. So then it will ask me that where are the lesions? So I'll say, for example, in this patient, proximal and mid RCA, there are two blockages which are more than 70%. I would leave the left main and I would say proximal LAD, and there is a proximal circumflex. So I'll choose these blockages which are more than 70%, and I hit this. It will say, is there a total occlusion, any CTO? And I'll say no. Any trifurcation? No. Any bifurcation? I say yes. And I'll say that proximal LAD has blockages in, say, like, for example, in the branches, and the angulation is 70. No aorto-ostial, means the start of the vessel is not involved and there is no tortuosity. The length of the blockage is more than, and if the calcification is there. So I'm just doing this as a case sample. There is no thrombus, means 100% artery which is closed by any clot. ACS is basically what we are looking at. So once I proceed, diffuse disease, narrowed segment, no, focal lesions, calculate the score. And it will tell me that in a case like that, the bypass and stents, 32% versus 28%. The blue line is CABG, and Texas were the first generation stents. So they're saying that cumulative event rate is higher with stents by 4%. Okay? So this is something that objectively can tell us that they're both very comparable. But what if our stents are 34% and CABG is by just 5 or 10%, the mortality or comorbidities? So in that case, you can actually decide whether this patient would benefit from doing, let me see if I can go back. It's a lot of questions, but I think probably it won't let me go back like this. So right dominant system. So we said this one is mid RCA. There is left main disease involving proximal and mid, like a long lesion. Circumflex, there is both obtuse marginal which are involved. Next, total occlusion, I would say yes. And let's put that RCA as total occlusion. Age of the total occlusion more than 3 months, I would say yes, it's a chronic source. So it's asking me that how does the stump look? I would say yes, it looks like a blunt stump. There is, yes, bridging collaterals. So it gives you a little technically how is it being filled. I mean, I would say that visualized segment is the distal one. So both are big branches. There's no trifurcation, no bifurcation, no osteal disease, tortuosity, no. Heavy calcification, yes. Thrombus, no. And continue and proceed. Diffuse segment, yes. So which one? I would say this one. So in a case like this, look at the difference. So bypass has much better outcomes as compared to the stents. 44% if I try to do stenting in this patient. So it tells you a very good objective evidence that the burden of disease, technically speaking, you define, and you can share this with your patient and educate them that even though they don't want bypass, if they choose to go for stent, it's a bumpy road. They might require multiple trips to the cath lab in coming years, requiring more stents, more complications, and the bypass from the very get-go might be a good option for them. So this is a tool that we use for our patients, Syntex score, and it actually has a Syntex 2 score added to it, which actually looks at their creatinine clearance, their clinical indicators, COPD, peripheral arterial disease. So you put that, and that will also factor in the clinical patient's outcome. What is his age? All those are calculated as well. So with that, I would